Hopkins to welcome everyone to the final webinar for this project, which is entitled Applying the Extended Parallel Process Model to Willingness to Respond in the Public Health System. I'm very pleased that we have a number of participants on the call who may not have been part of this project but are interested in some of the key findings, and so I'm going to tailor this call so that it addresses everyone's information needs. What I'd like to do is begin with an introduction to the project team, and I'm going to advance the slides here with. Okay, so the Project One research team includes myself, my colleague Natalie Seaman, Carol Thompson, Nicole Arrett, Krista Harrison, Doug Story, and Jonathan Links from the Center for Public Health Preparedness. And this has really been a collaborative effort. And I want to acknowledge from the outset the invaluable support from CDC, Office of Public Health Preparedness and Response in the Extramural Research Program, and very importantly, our practice partner collaborators, without whom this could not have been possible. And as you'll see from this presentation, we have a very large number of collaborators who've been wonderful to work with. This is a brief agenda for today's webinar. I'm going to begin with the introduction and background regarding this project. Then I'll proceed to a discussion of key project findings, recommendations, and next steps that we are currently working on. What I'd like to do is hold questions until the Q&A session, and you can type in questions and we will answer those questions and any others that you might have. We'll begin in the Q&A session with opening it up to participants in the actual project, and then open it broadly to everyone on the call, and then we'll adjourn. So I'd like to begin with a discussion of the presentation objectives for today, which include describe the influences of perceived threat and efficacy on willingness to respond in public health emergencies. The next objective is to describe scenario-specific patterns of response willingness. One of the take-home messages from today's webinar, hopefully, is that willingness to respond is a scenario-specific phenomenon. My willingness, for example, to respond to a weather-related emergency may not equate to my willingness to respond to a radiological emergency, for example. And the third objective is to identify potential interventions to enhance response willingness within the public health emergency preparedness system. So the goal of this project from the outset was not just to diagnose gaps in response willingness, but to identify an evidence-based set of interventions to address these gaps. So let's begin with some background, and I will be concise for those of you who have heard this. I want to move quickly through this, but I do want to reach all audiences here. We have a spectrum of public health emergency threats that we currently have to deal with, and it seems like these threats become broader by the day. And so this creates an ongoing challenge for a public health infrastructure that we know is, frankly, under duress right now, both in terms of financially and human resource capacity. So we have to do more with less, and that creates a challenge in the context of surge capacity. How do we maximize what limited resources we have in public health to address a broadening array of threats? Very importantly, this project began with a framework that was put forth by the Institute of Medicine and is depicted on this slide, where governmental public health infrastructure is at the heart of the public health emergency preparedness system. And in this project, we have focused explicitly on the local health department as the representative sort of center of this framework. Obviously, state health departments play a critical role, and some states don't have local health departments, so we're mindful of that. But based on the maxim that all disasters begin locally, we decided to focus on local health departments for this study. As you can see, around this sort of spoke and wheel framework, we have healthcare delivery systems, communities, academia, the media, employers and businesses, and homeland security and public safety. So with this framework, all of these different actors within the public health emergency preparedness system intersect and play a critically important role in collaborative response to all types of public health emergencies. One of the challenges in public health systems research regarding preparedness is how to define quality. How do you know it when you see it? If you were to ask most people, was the landing of the plane by Captain Sullenberger on the Hudson a successful event? Most people would say unreservedly yes. But how do we know that? What makes something a quality response? In clinical medicine, we have an abundance of quality metrics, but in emergency preparedness research, thankfully, these events are few and far between, but when they happen, they're high consequence. So it makes it a challenge to measure quality. And currently, we have been relying, at least here at Hopkins, on an IOM definition from 2002, which is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So the bottom line is that this definition could apply just as well to clinical care as it could to public health preparedness. And we are trying to refine that definition a little more robustly. And that's a current frontier of public health preparedness research. I promise this is the only Venn diagram that we'll be presenting during this webinar, but it's a very important one. We have come up with a framework here at our center at Hopkins that's based on a very common catchphrase, ready, willing, and able, to describe the requisite ingredients for a quality public health emergency response. And I'm going to define each of these in turn, but I want to highlight the fact that based on this framework, each of these constituents are necessary but not sufficient in themselves, and the degree of overlap of these three elements reflects the probability of a quality response. So obviously the goal is to maximize this degree of overlap. And we've gotten anecdotal feedback from jurisdictions that based on an article that we published on this framework, they've done some spontaneous translation of this research to adopt this framework for their own agencies. I'd like to talk about willingness to respond in this context, which is a state of being inclined or favorably predisposed in mind, individually or collectively towards specific responses. So the bottom line is, do I have the right attitude necessary to yield my response to a particular event? Will I show up to work? Do I have the right attitude to do so? And an abundance of research, including ours, points to a number of personal and contextual factors that contribute to response willingness. This has really been an elephant in the room for a very long time in public health preparedness. We've been doing trainings nationally, focusing on skill and knowledge building activities with a supposition that if you train someone how to look at anthrax under a microscope, that person will necessarily show up to work to look at anthrax under a microscope in the case of a laboratorian, for example. And our data, along with other researchers, strongly suggest that that is an incorrect assumption at best. And I'm going to present data that further highlight that point. So there are a variety of beliefs and understandings and role perceptions that are quite relevant that I'll talk about. And again, as I mentioned earlier, willingness to respond is a scenario-specific phenomenon. So just going through the elements of ready, willing, and able. Readiness refers to having the physical infrastructure in place. For example, can I physically get to work? Do the public transportation systems work in my jurisdiction during a disaster? Do I have plans in place? Do I know the content of those plans? And readiness applies not just at the organizational level, but at the individual level. Do I have a personal and family preparedness kit, for example, at the individual and household level? So you can think of readiness as the stuff or the physical infrastructure and planning elements that are necessary for a successful response. Willingness, in contrast to ability, is, again, the attitudinal dimension. So when you combine readiness and willingness, that equals response capacity. You need a workforce that is willing to show up and physically can show up. Additionally, once they have shown up to work, you need a workforce that knows what to do. And the ability piece refers to the requisite skills and knowledge that comprise effective response. But ability and willingness are not the same, and that's a take-home message from today. So we talk about response capability, which is predicated on ability, what the workers can do once they arrive on site, and response capacity, workers arriving on site in the first place. The ability piece is meaningless if you don't have people coming in the door to do their jobs. And what we're focusing on in this webinar is the factors that lead to people coming into the door to do their jobs. So by way of brief background, at Hopkins we have been looking at this issue of willingness to respond since actually before Hurricane Katrina. And in 2005, I should say, we did a pilot survey of 3 local health departments in Maryland, each of which served communities of 500,000 or fewer. And actually, based on local health department census data, 95% of local health departments serve communities of 500,000 or fewer. So it's the vast majority of health departments are the smaller ones. In this study, we found a few key findings that I want to highlight. At that time, we asked about pandemic flu and willingness to respond to it. H5N1 was the agent of chief concern. H1N1 wasn't even on the radar screen at that time. And we found that about half of the workers indicated that they would be unlikely to report to work in an influenza pandemic. So that was concerning in itself. But we also found something that surprised us, and it's referred to in this third bullet on this slide. We hypothesized various factors that might lead one in a health department to be more willing versus less willing to come to work. And we hypothesized that the most influential factor would be concerns about personal and family safety and wellness in a public health emergency. And that factor was actually very important, but it by far was not the most important factor. The most important factor, to our surprise in this pilot study, was the last bullet here, which is how important that employee perceived his or her role to be in the context of the agency's response. Notice I mentioned the word perceived. An employee can perceive his or her role as unimportant and be factually wrong about that. Oh, I just answer phones. Well, no, you're also on the front lines of risk communication when people call in with concerns during a public health crisis. And in this pilot study, we found that individuals who perceived their roles to be important in the context of the agency response were 9.5 times more likely to be willing to respond than their counterparts who perceived their roles to be unimportant. So that perception of importance in the agency matters greatly. And I'll talk more about that when we talk about the model that informs this research project. So I want to briefly discuss a survey instrument that we used from the project's inception and throughout, called the Johns Hopkins Public Health Infrastructure Response Survey Tool, or PHIRST. And this is an online survey instrument. It takes about 15 to 20 minutes to complete. And it asks about employees' willingness to respond and related attitudes, beliefs in 4 representative scenarios across the all hazards continuum. These include a weather-related crisis, pandemic influenza, a radiological dirty bomb, which is essentially TNT mixed with radionuclides. It's much more of a psychological threat than a physical one, and that's been well documented, but it nonetheless is a huge psychological threat. And inhalational anthrax bioterrorism event. Interestingly, each of these scenarios represent categories that are listed among the National Planning Scenarios event list. And we chose that for these scenarios for that reason. So I want to talk about the extended parallel process model. And this model is a behavioral model that was developed by a researcher named Kimberly Woody in 1992. She's at Michigan State. And it describes how people process messages in terms of threat and efficacy perception. And I'm going to walk you through this model, and hopefully this will become clear as I go through this presentation as to why this model is so useful for understanding willingness to respond. So let's say that I was trying to get someone to make a personal preparedness kit who did not have one yet. And we'll use that example throughout this walkthrough. The model says that I need to do two things. I need to convince someone that there's a legitimate threat out there that's worth making a kit for, so that I can convince the listener that there's a threat that is motivating them to action. And I need to convince them of what's called efficacy. And I'll talk about each of these elements. So threat comprises perceived susceptibility. Is this event likely to affect me? If you were trying to tell people to make a snowstorm kit in Miami, Florida, that's a non-starter, for example. So these have to be relevant perceived threats that motivate you to action. The other aspect of perceived threat is severity, according to this model. If this were to happen to me, do I think it would have a severe impact on me and my family, for example? The other major component of this model is the efficacy piece. And there are two components of efficacy according to the extended parallel process model. There's something called self-efficacy, which is I feel confident that I can do X, whatever X is. I can make a kit, for example. It's not that expensive. I can readily assemble one. I know what it should contain, those kinds of issues. Response efficacy, on the other hand, means that if I make a kit, do I think it'll actually make a difference? Do I think it will keep me and my family safer? So here's how the model plays out. If I am unable, according to this model, to convince the listener that there's a legitimate threat that warrants making a kit in the first place, that listener will disregard my message out of hand and will not engage in the desired behavior. In this case, will not make a preparedness kit. So that will result in message rejection. But let's say that I'm successful in convincing the listener of the legitimacy of the threat. Okay, so far so good. But let's say that I fail to convince the listener of the efficacy of making a kit. So now I've frightened the listener, and the listener has a low sense of efficacy about making a kit. That's a very bad place to be psychologically. And according to this model, that results in the listener responding to his or her fear of the scenario rather than doing something constructively to manage that fear. And Whitty calls that fear control, and that scenario ultimately, according to the model, will lead to message rejection. According to the model, though, if I'm able to successfully convince the listener that there is a legitimate threat that's worth making a kit for, and that making a kit is something that they can easily do or readily do and makes a difference, then I've convinced them of both the threat and the efficacy pieces, which leads to something very positive and proactive called danger control, where you're actually taking constructive action to manage the hazard rather than your fear of that hazard. And that ultimately will translate, according to this model, into message acceptance. Now, there's an old expression that you'll see in data from our own study that says that all models are wrong and some are useful. And that is no less true in this case. This is a very powerful model, but one of the things we'll highlight is the relationship between efficacy and threat as it relates to willingness to respond based on our data. So just very briefly, we at the center have incorporated threat and efficacy appraisal into our survey, the Johns Hopkins Public Health Infrastructure Response Survey tool. So these are listed on this slide, and we'll make this slide set available on our center's website subsequently. And we ask these questions for each of the 4 scenarios. This is just a screenshot. We ask about basic demographic questions in terms of job, title or type, highest educational degree, and various other relevant factors to give us a sense of patterns in terms of health department composition. And this is a Likert scale snapshot. Again, we use a Likert scale for this study, an odd-numbered Likert scale on purpose because there's research that suggests that if someone answers neutrally, that's different than don't know. So we include a don't know option in addition to a neutral option for this particular survey. Okay, So based on this model, you can divide your agencies into 4 types of people. And these types are summarized on this slide. For purposes of shorthand, concern means threat, confidence means efficacy. So the first group is the low concern, low confidence group. I'm not worried about this threat, and if it happened, I don't think I could handle it anyway group. This is not a good place to be with regard to willingness to respond, as our data will show. And that's a group for which we want to educate about the threat and build that sense of efficacy. The next group is the low concern, high confidence group. I'm not particularly worried about this threat, but if it happened, I feel that I could manage it and that I make a difference in my agency's response if I show up. The third group is not a good place to be with regard to response willingness, and that's the concerned with low confidence group. These are the frightened individuals who have a low sense of efficacy. And that is a group that will have a low rate of willingness to respond based on an abundance of data from our study. If you had to identify one profile of a public health worker who's most likely to be willing to respond across all hazards, it's this last bullet. It's what we call the concerned and confident worker, the worker who couples high concern with high confidence. And by high concern, I don't mean a concern out of proportion to the actual threat, but proportionate to the actual threat, a healthy dose of concern that's motivational, coupled with a high sense of efficacy. So these are the 4 groups, with this last group being sort of the gold standard, if you will. There are exceptions, and we'll talk about that. But if you had to pick one, it's this last bullet. Now, in this study, we've been able to look at willingness to respond among a variety of cohorts, including pre-hospital workers, so EMS personnel, volunteers. We have a manuscript in press regarding willingness to respond among MRC volunteers, hospital workers, we've published extensively on that, and local health department workers, which we've focused on in our publications, and is really at the heart of this study and what we're going to focus on for the purposes of today's webinar. So this last bullet, local health departments, is the focus here. So I'm going to give a little bit of a spoiler here, but I'm going to present this now and then show why these findings are relevant based on the data. So our overarching findings from this study is that, as I mentioned, if you had to pick one profile, it's the concerned and confident profile. That's the public health worker that's most likely to be willing to respond across the hazards that we've studied. Another critical finding is that efficacy weighs more than threat. So that, contrary to what the model would predict, even if a public health worker does not have a high sense of perceived threat, as long as that worker has a high sense of efficacy, that individual is much more likely to be willing to respond than the low threat, low efficacy worker, the I'm not worried about it and I don't think I could handle it anyway type of profile. And very importantly, our study has strikingly consistently demonstrated a gap in willingness to respond to a radiological event. And this is basically a concern that relates to national health security. We know that radiological threats are pervasive, whether it's an accident such as Fukushima or an intentional act involving radiation. And in public health workers are generally not the ones with the level A suits, but they are the ones who provide risk communication to the people wearing the level A suits. So the risk communication component of radiological preparedness and response is part of the purview of public health response. And so we have a lot of data that relate to that. And just as a reminder, we will have Q&A regarding all of these points at the end, but feel free to type questions into your control panel now if you want. So I'd like to present data now on the local health department workforce, which, as I said, has been the focus of our study. And we basically started the study with some key specific aims, which I'm going to recap here. We wanted to characterize scenario-based differences in emergency response willingness using this extended parallel process model, referred by shorthand as EPPM here, to identify common patterns across agencies, across regions, and across jurisdictional types. So we administered this survey, the PHIRST survey, to what we call clusters of local health departments. By clusters from this study, I mean a group of contiguous or adjacent local health departments, typically within a single state, in one case across state lines. But, for example, 3 adjacent counties or bordering counties or nearby counties would comprise a cluster. We've had clusters in this study that have ranged up to 15 health departments that are within a certain region of a given state. So it's varied in size in terms of number of health departments per cluster. We've also looked at multiple FEMA regions to get some variation in terms of geographic and administrative composition, as well as urban versus rural jurisdictional size. For urban versus rural, as you likely well know, there are as many definitions of urban and rural as there are agencies that define them, unfortunately. We used an American Journal of Public Health article from 2002 that basically defined urban health department versus rural, and we used a 50,000 resident cutoff for urban and rural. So it's not a perfect definition, but at least we were able to rely on something from the literature to underpin our categorization there. So here's how the study worked. We, at the very beginning, randomly divided clusters of health departments, and we had 8 clusters of health departments that entered the study at various points in time. And we administered for each cluster, we administered this survey at baseline. We randomly divided these clusters, health departments within each cluster, into intervention and control health departments. The intervention health departments would get a novel research curricular intervention that I'll talk about that's explicitly designed to boost willingness to respond. The control group did not get this intervention until after the research process was done. So we administered this survey at baseline. Then we did multiple resurveys at various points in time after the intervention had been administered. And we resurveyed both intervention and control health departments because we wanted to see if the intervention made a difference. We also conducted focus groups to get qualitative data in addition to the quantitative data from the survey. So this is a mixed methods design research project. Very importantly, and I'll talk about this more, we used for the curricular intervention a train the trainer model. And the name of the training, which I'll talk about, is called Public Health Infrastructure Training, or FIT. So we'll talk more about that in a bit. Oops. Can we back this up? Okay, great. Sorry about that. Okay, so let's talk about the clusters that were involved in this study. And again, we thank them tremendously for their engagement, for a very exciting collaboration. We had 4 rural health department clusters. These are listed here, one from Idaho, one from a group of health departments in southwestern Minnesota, one from a group in southeast Missouri, and a health department cluster from a rural area in Virginia. We had 4 urban health department clusters, one from southeast Florida, one from the greater Indianapolis metro area, one from the greater Milwaukee region in Wisconsin, and one that actually crossed state lines but comprised the Portland metropolitan area. So that included Oregon and Washington state. So we had a balance between 4 rural and 4 urban clusters, which was what we desired to have. A couple of introductory findings that I think are of practical relevance, and we can talk more about those later. This slide describes the baseline findings. These are all respondents. We had a total of 2,997 participants in this study, comprising 71 local health departments across 9 states. And these are baseline results that I'm presenting here. And to our knowledge, this is the largest study of local health department-based willingness to respond that's been conducted to date. Key findings from this table are as follows. If you were to cut this slide in half from left to right, and you look at the first 2 columns, weather-related events and pandemic influenza, versus the columns on the right, radiological dirty bomb and anthrax bioterrorism, you'll see that willingness to respond to a naturally occurring event is greater than willingness to respond to a terrorism-related event. So that's a key finding from this slide. Another major trend that we see is that within each scenario category, for example, take dirty bomb, which is highlighted in the red box, willingness is greatest when the employee perceives or knows that he or she is required to come to work. It is next highest if the employee perceives or knows that he is or she is asked but not required to come to work. And the lowest rate for each given scenario is regardless of severity. Ultimately, though, you want to know as a public health administrator who is going to show up no matter how severe the event is. And so that last row is very important. So expectations matter. That's the take-home message from this slide. Agency expectations matter, and employees' perceptions of those expectations matter with regard to response willingness. Another trend that we found quite interesting, we were not necessarily expecting from this study, is that for each respective scenario that we looked at, willingness was higher in rural jurisdictions than urban ones. And this was an interesting finding that we subsequently explored through focus group discussions. And it's something that is worthy, we think, of further research, these gradations between rural versus urban willingness to respond. Some of our focus group findings pointed toward a sense of social cohesion that exists in particularly small health departments, where if you don't show up and you're in a health department with 8 people, the other 7 know who you are. If you are in a health department with 1,300 employees and you don't show up, maybe the other 1,299 don't recognize your absence. So that is a key finding. But again, regardless of rural or urban, we see that the lowest willingness to respond rate, as in the last slide, is for the radiological dirty bomb scenario. And I should mention that between the preliminary data that led to this grant and throughout the duration of this grant, there was not a single exception where the dirty bomb wasn't the lowest willingness to respond scenario. So this is a consistent theme that we're seeing. The notion of when you've seen one health department, you've seen one health department does not apply in this case. So our findings raise the question of how can we further address gaps in willingness to respond. And as I said earlier, our goal in this study was not just to diagnose gaps in response willingness, but to actually do something to address them in an evidence-based fashion. So that brings us to our discussion of the public health infrastructure training, which was the experimental curriculum that we used in this study for the intervention arm. This study was a train-the-trainer curriculum comprising 7 hours of learning time delivered over ideally a 6-month period. Some clusters finished faster than 6 months, others took a little longer, but roughly 6 months was the typical length. The idea of this curriculum was to use the extended parallel process model to sort of extend awareness of threat, as well as couple that with a sense of efficacy, just as the model displays. This is a learning management system curriculum. So for those of you who are familiar with TRAIN, we used an analogous learning management system based at Hopkins to allow us to track the progress of participants in this curriculum over time. And it's a blended learning approach, which includes face-to-face lecture and discussion activities, online learning, independent activities, case scenarios, tabletop exercises, and various other modalities. And I'll walk you through these. So this curriculum, the table of contents, includes 3 parts. And this is the sequence that we used for it. The first part was a facilitator-led discussion in which the person we had done the trainer for, the health department-based trainers, talked with their colleagues about an overview of the scenarios that we examined in the survey and what public health's role would be with regard to each of those scenarios. For example, the importance of risk communication in a radiological emergency from a public health standpoint. The other part of this first phase of the curriculum was what we called an emergency scenario contingency planning exercise, which basically tried to highlight the ripple effect of an employee's individual decision whether or not to come to work, highlighting the fact that if you decide not to come to work and are physically otherwise able to do so, it has effects not only on yourself, but on your family, your agency, and more broadly, your community. So that was the first phase of the curriculum, comprising 2 hours of learning time. The second phase was a group of independent learning activities, which included making a personal and family preparedness kit. We actually required that as part of this curriculum. Mapping out multiple routes to work using Google Maps or a similar program. And finally, taking 3 online learning modules that are based on gaps highlighted in the baseline survey. So these 3 learning modules included crisis risk communication in public health emergencies, radiological risk communication in public health emergencies, and mental health self-care factors for public health workers in such events. The third part of the curriculum was a group experiential learning activity comprising 2 hours of learning time. This included a tabletop exercise geared toward the scenario which had the lowest baseline rate in the survey, which without exception turned out to be the radiological scenario. There was a role-playing exercise involving a hotline set up at the agency based on that scenario. And finally, a debriefing activity in which participants talked with the facilitator about the overarching curriculum, key findings, lessons learned, and reflections. So ultimately, we were interested to learn whether this intervention made a difference, whether the public health infrastructure training actually had an impact on willingness to respond. And the findings are summarized here. We've highlighted a few trend lines. So basically the way to read each cell is let's take a look, for example, at the intervention row, which is highlighted with a red rectangle. Under weather-related emergencies, 79% is the baseline willingness to respond rate. These, by the way, are for individuals who responded to all 3 surveys. So the 79% is at baseline, 80% is at resurvey 1, 79% is at resurvey 2. Not much of an impact for the naturally occurring scenarios. Similar is the case with pandemic influenza. On the other hand, for more exotic and terrorism-related scenarios, this curriculum did have a significant impact on response willingness. And in our original grant proposal, our hypothesis was that we would raise the rate of willingness to respond by approximately 15% for the scenario that had the lowest baseline rate. And that actually was borne out here for the radiological scenario, which, as I mentioned, was invariably the one that had the lowest baseline rate. We also see increases in response willingness to anthrax bioterrorism. And so that's another instance where you can divide the table in half, and it does seem to have that effect. The curriculum seemed to have an effect on scenarios relating to terrorism particularly. On this next slide, I'm highlighting self-efficacy. A key take-home message from this research project is that of all the factors that underpin or influence response willingness, self-efficacy is the leading one across the board. There are a few exceptions, but in general, across scenario categories, if you had to pick one influential modifier, it's self-efficacy, which is how confident do I feel that I could do my job effectively in an emergency. What we've seen here is that, again, the greatest impacts are for the terrorism scenarios, but there was a modest impact, for example, for the weather-related emergency that held over time, and that's encouraging to see. Response efficacy is how important do I perceive my role to be in the context of the overall agency response. Again, based on our pilot study that I mentioned from pre-Hurricane Katrina, that was a leading modifier of willingness to respond. We see, again, less of an impact over time for the naturally occurring scenarios, but more of an impact over time for the terrorism-related scenarios. So these are trends that we're observing over time in our study. And this reflects baseline and resurvey 1 and resurvey 2. The resurvey 1 was conducted approximately 1 week to 1 month, typically after the completion of the intervention. Resurvey 2 was done approximately 6 months after completion of the curricular intervention. And it's always good to see in this type of research when control groups either trend downwards over time or don't show the same kind of impact that intervention groups do. And we see the control groups really had that pattern here. So there was a difference between intervention and control. And from our study, we know that there were no willingness to respond curricula of other types that were included in the interim. So this was a unique curriculum that was conducted during the lifetime of the study. Psychological preparedness is a critical part of resiliency, and we see improvements actually even for the naturally occurring scenarios from this curriculum for psychological preparedness, particularly profound in the radiological emergency, an increase of approximately 30% that pretty much held over time even for the resurvey 2. We also see significant increases in the anthrax bioterrorism scenario with regard to psychological preparedness. So, as I mentioned earlier, this was a mixed methods research study, and the qualitative component included focus groups, which we conducted on site in sync with our resurveys throughout the study. A couple of key findings that I want to highlight are listed here. Participants reported increased understanding of their roles. And this was a finding that we observed across the board, but particularly profoundly for the radiological dirty bomb events, and more generally with regard to communication to the public. As I mentioned, in public health, not the level A suit wearers, but the ones who communicate risk to those who wear the level A suits. And this, by the way, these focus group findings, I should mention, are for the intervention group. We did the focus groups exclusively to gauge the impact of the curriculum, and that's why this is just from the intervention group. Participants in this curriculum reported increased understanding of the importance of their roles, which was very important for us to observe, as well as the potential impacts that they have on the health department and their community if they choose not to respond. So the component of the curriculum that talks about the ripple effect of not showing up appeared to resonate, at least with regard to much of the focus group discussions. In many ways, this study was a natural experiment. It was concurrent with H1N1 to a large degree, and it turned out that the confluence of the training and H1N1 response really led to almost a synergistic enhanced understanding of public health workers' sense of importance of their role and their perceived ability to do that role effectively in several of the clusters that we studied. Some findings from our focus groups were that some focus group participants, particularly those in rural areas, felt that the radiological dirty bomb scenario was a less realistic one, and that may be a fair notion. On the other hand, individuals who are evacuating large cities will be passing through rural areas, so it still has relevance even for rural jurisdictions in that regard. Very importantly, the importance of feeling confident and in terms of your own safety and the safety of one's family was a very powerful modifier of response willingness. So that relates to making a personal and family preparedness kit, which was a requirement of this curriculum. Importantly also, we got feedback that this training provided a unique opportunity for public health employees to discuss limitations to their own agency's response plans. And in many cases, we learned from participants that this was one of the first times that these kinds of issues had sort of organically emerged. We also made it a point during this curriculum to include administrators with line staff within the same training, and that was novel for a number of agencies. So it gave an opportunity for a dialogue between leadership and line staff that was value added from the perspective of these agencies. Some health department clusters indicated to us that their agencies still had some work to do in defining health department and employee roles and responsibilities. And again, preparedness is an ongoing process, so this is not unexpected. But it's something that, from the feedback we received, was a beneficial insight for them. So based on our study, we have some evidence-based recommendations that I'm going to share here. And again, these are based on the data, and these are aggregate recommendations. So we provided a final report for each particular cluster, but this reflects some cross-cutting themes that we observed across the clusters in terms of recommendations. So here are training recommendations based on our data. One is that we need awareness level trainings to educate the workforce on agency plans for worker safety during emergencies. One of the most influential modifiers of response willingness is feeling safe at work while you're responding to an event. And these data are not just things that we've observed, but there's been other excellent research that has looked at the importance of perceived safety at work, and it's been found elsewhere to be a leading modifier, for example, in hospital settings. Personal and family preparedness planning is a critical ingredient for willingness to respond. We have data that suggests that strongly, and that's an issue that should be included in trainings. Now, we'll talk about the implications of that, because if your agency is requiring you to make a personal and family preparedness kit, but not providing the financial resources to do so, you can consider that potentially an unfunded mandate. And at a time when public health is struggling with financial constraints, that could be a challenge. But nonetheless, we've found that that's a very critical ingredient in boosting employees' willingness to respond. Radiological preparedness training is critical. This is a gap, as I mentioned, that literally without exception was observed across all of the health departments in this study. And this applies to new hires as well as those, and when I say new hires for clusters that participated in this study. If you have not participated in this study, this relates across the board because we did not find demographic differences in willingness to respond to radiological emergencies between people who had worked at the health department for 10 years, say, versus those who were newer on board at the health department. It's critically important to continue to exercise and drill on specific emergency roles for all staff. And I emphasize all staff because a number of employees in this study expressed initial insights to us that they felt that their roles were marginal with regard to other employees. And that's a concern. This is an all-hands-on-deck construct where the events of the kinds of severity that we're looking at require an agency-wide robust response, and therefore all staff play a critical role, and employees need to know how they fit in to their overall agency response. Implementing multiple routes to work or modes of transportation to work sites are critical, and exercising on those elements are critical. Now, if you live in a small rural area, there may be only one route of ingress and egress, so it may be more or less relevant depending on the jurisdictional size. But nonetheless, even in small rural areas, sometimes there are multiple routes to get to work, and it's important to focus on that. For a long time, we've been talking in public health preparedness about dual-use applications of preparedness activities, meaning the ability to translate preparedness knowledge and skill sets, or in this case, attitudinal elements, toward day-to-day activities. And that's no less relevant here. So this is something that health departments can do to enhance employee readiness by focusing on the dual-use applicability, let's say, of a health educator's skill set toward how that would apply to an emergency as well. Very importantly, from this study, we learned about the importance of cross-pollinating ideas across departments within public health agencies. Some health agencies are very siloed, others are more centralized. Again, that's one of those examples where it's very health department specific, but it's really critical in the context of preparedness training to ensure cohesion across departments, even in the largest health departments, and in fact, especially in the largest health departments, where you can have a lot of potential for siloing among different departments. This is an ongoing iterative process, so continue training to maintain improvements in willingness to respond. That's something that should be an aim moving forward. Here are some policy and programmatic recommendations. So I just talked about training recommendations. Here are some policy and programmatic ones that are based on our data. One of the key such recommendations is to ensure worker safety during emergencies. And very importantly, just as importantly, communicate what those plans are. So if you're an administrator of a health department and you've got a plan for personal protective equipment, it doesn't serve your employees for you to have such equipment but not communicate what those resources are to your employees. So that's one of those examples where you have to have the plan and communicate it effectively. Requiring employees to have a personal and family preparedness kit, easier said than done, But nonetheless, we have data that suggests that it's a very important positive modifier of response willingness, because employees feel more comfortable coming to work knowing their families are optimally protected in their absence. Very importantly, a perceived or actual requirement to report to work during emergencies is very important. It matters greatly. And this is an example where when you've seen one health department, you've seen one health department. Different agencies have different organizational policies regarding required participation in emergency response. One of my favorite examples is a local health department in Maryland whose health officer is a former military member, and he said, "I can't force you to come to work, but we can revisit your employment status afterwards." Now, that's one way of doing it. But different agencies have taken different approaches, and we need to think about the relevance of our findings here, where when you perceive that you're required to come to work, regardless of scenario, you're more willing to show up than if you think that your attendance is optional. Agencies need to continue to encourage workforce response during times of emergency in a way that highlights each employee's relevance and importance. So one of the common themes that we observed is that sometimes employees were anxious about what might my role be. Would it be beyond the scope of my day-to-day skill sets? Well, the answer is really no. If you're in fiscal, we're not going to ask you to vaccinate people. But you may be very actively involved with inventory management and the budgetary aspects of response. So sort of highlighting the relevance of employees' day-to-day activities and skills to how they would translate to emergency response is a critical element in boosting response willingness. And ultimately, this means that we need to have ongoing, effective, and reliable communication with our workforce. If you are a public health administrator, this is not a one-stop deal or a one-off kind of scenario where you communicate it and then that's the last employees hear about it. This requires regular reminders and reinforcements to ensure that these gains can be maintained. A few other policy and programmatic recommendations are that this extended parallel process model framework can be very useful, we found from data, as I've shown, to encourage the development of training programs that focus on willingness, not ability per se. We already have an abundance of ability-focused training programs, and those can always be improved, but we don't have enough training programs in the United States for preparedness that focus on willingness as a discrete outcome. And this study highlights the utility of this model for boosting willingness as a discrete attitudinal outcome, particularly for terrorism scenarios or more exotic scenarios that may be associated with lower baseline rates to begin with. We want to encourage both self-efficacy and response efficacy, but the self-efficacy piece is very important, as I mentioned earlier, and highlighting the critical role that all employees have to play in an emergency response. Encouraging personal and family preparedness for employees is something we've talked about, but that's something that needs to be addressed at a jurisdictional level. How are you going to prioritize funding within your agencies, for example, to subsidize, let's say, if you wanted to, employees to make a personal and family preparedness kit? That's a relevant issue. You need to, or may need to if you haven't already, reconsider what are your current organizational expectations toward response requirements. There are union issues and all sorts of challenging issues with regard to requiring someone to come to work. But these are things that need to be addressed now rather than later. And finally, an increasing focus on curricula that address preparation for a radiological emergency. Again, this was a profound gap that we observed across the board and across time in health departments. And we also, by the way, I should mention, observed this across other cohorts that we studied during the lifetime of this research project. For example, among hospital workers, Medical Reserve Corps volunteers. These are elements that affect other aspects of the public health emergency preparedness system, not just the local health department workforce. So what are some current and next steps that we're engaged in this research project as we are on the home stretch? Well, we've already prepared cluster-specific final summary reports and distributed those to participating health department clusters. And these are written reports that we've sent out. We have a number of manuscripts either in press or under review currently, focusing, for example, on the impact of the FIT curriculum pre versus post for all the clusters. And we're very excited about a new initiative in which we're adapting this public health infrastructure training, which was designed in the study for health departments. We're adapting it for hospital settings because we think it can have applicability for hospital contexts as well. The next set of slides are some references. Virtually all of these are open access journals, and we've intentionally published in open access journals to maximize the reach for busy practitioners, and these don't require a subscription. These can be easily accessed via the internet. And at this time, I would like to take questions. We'd like to begin. So we're just getting this set up for audio use. There was attenuation, especially between, for example, second and third resurvey 1. And in terms of recommendations, we think that drills and exercises that are strategically timed to reinforce some of these critical issues of willingness to respond are very important, as well as refresher trainings. We use surveys that one week out and 6 months out, and it just shows how quickly some of these concepts can erode unless continue to infuse this into your organizational culture. So this requires continued communications, ongoing refresher trainings, and tabletop exercises regularly conducted in the gains.
Because at that point, you know, it's like, who would have been one of the smaller ones, but they know.
So I've got the the WISE provider network list up on my computer, so we just need to make sure they get her into one of those facilities.
Remember them the day when they would answer?
Hey.
Or
I don't know. All listed right here on this piece of paper and they're up online here. All right, well, thank you so much.
Folks, we're unmuting the line, so if you still have an open line.
No, you don't have. No, that's what you're hearing. So
they only cover, instead of covering 80%, insurance is covering 60%.
The only one that
I'm sorry. If you have an open line,
I just muted everybody again.
Just to let you know, we're about to unmute the line. So if you have a question, please ask. But if you don't have a question, just please mute your line. Thanks. Just want to make sure we get all the questions in. Let me ask or address another question that's a write-in. On page 20 of the final report delivered in December 2012, the following was reported. Certain groups, for example, nurses, were described as more committed to coming to work than others. Do we have statistics for the different status of public health professionals? For example, nurses versus food specialists versus wastewater or water sewer specialists and their willingness to respond to any of these incidents. Also, I may have missed it because I joined a little late, but did you find any significant association between age and education status of the public health professionals and their willingness to respond? Let me begin with the last question first. We did not find consistent demographic differences based on age or any of the other factors. And this is, again, reporting in the aggregate. So the first part of the question was a very cluster-specific question, which we are happy to delve more into. But in general, we really did not see, there may have been some minor differences, but they were not statistically significant differences. So that actually should be reassuring, because it means that a lot of these concepts apply agency-wide. Do we have other write-in questions?
I'm going to have to ask everyone, because I'm having a hard time unmuting the callers. I think it's because we have so many callers on the line. So if there are additional questions, please feel free to write in, and I can unmute your line individually. I apologize for that. Here's another one. Did you look at health department preparedness plans?
Okay, so did we look at health department preparedness plans is another write-in question. A great question. We, during our focus group discussions, talked about employees with regard to what their plans were for their agencies. And in some cases, we really have valued this. Employees were very candid and said either there's not a plan or we don't know what the plan is. And I think that speaks to the importance of communication of the plan, and obviously having a plan in the first place to communicate. One of the value adds that we heard back from participants was that this study revealed gaps in planning in some cases that agencies were subsequently able to address. And so these kinds of trainings where you have leaders and line staff in the same room allow for a recognition of gaps that can be subsequently addressed. Great question.
Okay.
You state perceived value 9.5 increased response. What increase did you find from perceived family preparedness? It was approximately, from the original study in the 3 health departments in Maryland, I don't recall the exact number, but it was more in the odds ratio of 4 to 6 range, which was, again, very significant. I mean, anytime you have a statistically significant odds ratio of 2 or greater, that's a publishable finding and significant one operationally. So, again, this is not to diminish the other factors regarding willingness to respond, but it's to highlight that the perceived importance of one's role was by far the most important. But the other issue did have a very high odds ratio attached to it, which again speaks to the importance of personal and family preparedness kit making as part of institutional planning, if at all feasible. You have another question?
No.
Okay. So can we have people or
I think the issue is that you can only unmute so many lines at once, and there's more than the maximum number.
Okay.
So if we could have folks, which I've just asked, if you have questions, to please type them into the control panel, and we can respond that way.
Great. So please do type in your questions, and thank you for your excellent questions so far.
Okay.
In the presentation, financial constraints were referred to a couple of times. How do you foresee the effects of this diminished preparedness funding on the preparedness of the health department? Well, this is a very apt question. It's a very real concern. My sense from this study and the data that we've compiled is that it's going to have a significant impact. We have already documented gaps in willingness, and when you have a shrinking public health workforce due to financial constraints, those gaps become amplified in terms of their operational relevance. So I think this has a significant impact on national health security, not just on individual agency response. As I showed in one of the earlier slides from the IOM report, health departments are really at the hub of the public health emergency preparedness system. So I think this speaks to 2 things. One, this is a real threat to public health preparedness, and 2, we really do have to focus on getting people in the door in the first place through willingness-oriented trainings much more aggressively than we have been nationally to date. Great question. How many health departments that were surveyed had a written requirement to work during disasters as a condition of employment? I will be candid with you, we did not take a straw poll or otherwise. I have talked with a number of my colleagues who are public health lawyers and have asked them if you can physically compel someone or drag them out of bed to come to work. You cannot legally do so. However, a number of, just anecdotally speaking, a number of health departments do have, that we work with, do have such requirements. The exact number, I don't know. But it really varied from one health department to the next. And that's one of the issues I think that requires further research, is looking at agency patterns for encouraging response. What are different health departments doing? What works best? What I can say from the data is that the perceived requirement works best, however that may play out. Some health departments that we've talked to have written it into new employee hire contracts. Others have not. So it really varies from one health department to the next.
The next question is, how many of the health departments surveyed had preparedness coordinators?
Natalie, do you know?
There was always a representative for the health department. Sometimes it wasn't a preparedness coordinator, a one-to-one ratio per each health department. Sometimes they were shared among regional health departments. But there was always someone who was serving in that role.
Great, thank you. Can you access the PHIRST survey and use it on your own, or do we need to work with the researchers? How is the training you provided accessible? And also, please provide the link for obtaining the slides from your presentation, which includes your publications. Natalie, do you want to speak to that?
So the first survey that we use requires a very sophisticated statistical analysis, which fortunately we have folks here at Hopkins that do that for us. So it's not at this point able to be used independently by health departments or other agencies. And as you may know, this project has been ongoing for the last 5 years. This is the last year of this particular project. So at this point, we aren't able to continue to distribute the survey. The purpose for today, and one of the reasons that we were happy to have other attendees on the call who are representing agencies that didn't have possibly the opportunity to participate in this research project, was also to highlight the consistency of our findings across clusters over the last few years, and actually from our pilot work for the years before that, and to show how the curriculum that we have designed does address gaps in willingness to respond. And we're happy to report that although we may not have the funding in the future to continue the survey, or actually to help deliver the training curriculum in a train-the-trainer format, elements of the training will continue to be made available through our online training management system, so that health departments that are interested in using a curriculum that has a proven record of success in boosting willingness to respond will have access to that. So at this particular point in time, those are our current plans for making things available. As far as the slides for this presentation and the audio for this presentation as well, we're planning to make this available on our website. So anyone who wasn't able to join in or had any technical difficulties should be able to access this at a later date, and we can send an email out to the participants to let them know when this is available.
Great. Do we have other questions? Okay, so regarding the preparedness coordinator question, was preparedness these individuals' full-time or part-time position, or was it a mix? I'm seeing far too often that preparedness activities are put on the back burner because it is considered a secondary duty. Now, would you like to speak to that?
We didn't, in our survey, ask specifically whether or not this was their full-time or part-time position. However, just anecdotally working with some of these folks, I think it just depended on the health department. I think some of the larger health departments, perhaps in the more urban settings, likely had someone where this was a dedicated position. In some of the rural health departments, those were the areas where you saw, where we tended to see preparedness coordinators that, served in that role over a variety of health departments or served in that role along with other job duties. So consistently, I don't think that we saw a pattern for how that worked, but obviously, I think Curtis, your thoughts are relevant. That in many cases, I think that it's not always someone's primary job. It's a mix of different positions.
Is there a resource/list available specific to personal family preparedness kits for public health workers, or are general recommendations sufficient? Great question. We use the American Red Cross guidance sheet for the elements of a personal and family preparedness kit. There is a sort of a basic kit and a more deluxe kit, for lack of a better term. We chose the more basic kit that we thought would be easier to prepare and more feasible for health departments to use, and that's on the American Red Cross website.
And just as a follow-on to that, though, some of the clusters that we worked with were in states or regions or what have you that they had developed guidance for building personal and family preparedness kits, and where those standards and guidelines were available for those particular jurisdictions, we deferred to what their state requirements were.
Right.
Okay, one last question.
Will the health departments get copies of the upcoming publications? Well, we are absolutely going to provide copies to the participating health departments of upcoming publications if they're not in open access journals. And if they're in open access journals, they're open to everybody. So, for example, PLOS1 is a journal that we've published in, BMC Public Health. It just simply requires internet access, and you can access the full text article. But for those that may not be in open access journals, we will make sure that participating health departments and others who are interested have copies of it.
And on our center's website, we keep a running list of all of our publications, and if we can do so, we also provide links to the open access journals. So you can regularly visit our website to see what new publications are out there.
How will you seek feedback from research participants on the appropriateness and feasibility of implementing the training, policy, and program recommendations from your findings? Basically, we have been trying to do that through our focus group approach, and that's been a very valuable element for us to get that type of feedback. So we've been sort of eliciting or soliciting feedback, I should say, from them, from our participant health departments from day one. We're always open to further feedback. So you have my contact information on the last slide of the PowerPoint, and I'm always happy to take follow-on questions and insights from participating agencies or otherwise. And I should also mention that this is truly a collaborative project. So our co-authors on our manuscripts are also points of contact from participating health departments. So that's something that you'll observe when you look at the publication list. You'll see a long list of co-authors, and these are all members of either Hopkins or representatives from participating health departments who were interested in participating as co-authors. So we've taken a variety of approaches to that. Okay, any other questions? Great. Well, I want to thank everyone for the opportunity to present this research to you. It's been an exciting process for us. I want to thank, again, CDC and our practice partner colleagues and the team from Hopkins for all of their excellent work to really make this study a reality. This had a lot of moving parts, and thankfully we were able to provide some generalizable insights that hopefully will be of value to you moving forward when you think about willingness to respond.
And I apologize for some of the issues with our audio, but appreciate your typing fingers to provide the questions in place of actual discussion. So if there are other questions, then moving forward, there is contact information, which I will make available one last time for Dan, just on that last screen. So if you need to reach out with additional thoughts that you might have after we're done here, we're still around. So thank you all for attending.
Thank you.
Oh, gosh, I can't do it.